For a temporal approach to the patient's left eye, a conjunctival flap is dissected from 1 to 5 o'clock, giving good limbal exposure. Gentle diathermy is applied to bleeding points and vascular areas. A crescent blade makes a partial thickness groove just behind the limbus, which is extended 2 to 3 millimeters into clear cornea. At this point, before the anterior chamber is entered, a capsulotomy is performed. The bevel of a 27-gauge needle attached to a syringe containing Ringer's lactate is used like a knife to make 2 incisions with fine chopping motions in the anterior capsule. Thus, a triangular flap of anterior capsule, still attached at its base, is created. The apex of the capsulotomy is stripped inferiorly with the tip of the needle. The anterior chamber is now entered through the sclerocorneal tunnel using a lancet keratome. An irrigating Simcoe cannula delivers the nucleus into the anterior chamber by nudging one edge of the nucleus into the anterior chamber and then delineating the cleavage between the iris and the lens until the lens is entirely delivered into the anterior chamber. A corrugated irrigating nuclear extractor is passed posterior to the nucleus, placing the tip beyond the distal pole. Gentle lifting and retraction with the cannula, plus opening of the external foramen with gentle downward pressure from the heel of the cannula, facilitates nuclear delivery. Debris is then removed using the Simcoe cannula, and an air bubble or viscoelastic is instilled into the anterior chamber. As the posterior chamber intraocular lens is inserted, the leading haptic folds the cornea inward, trapping air within the anterior chamber, and is then directed behind the capsular flap into the capsular bag. The trailing haptic is placed behind the capsular edge superiorly with a combination of intraocular lens rotation and gentle posterior pressure. Fine positioning of the intraocular lens is achieved with the Simcoe cannula. The anterior capsular flap is now removed. Van Ness scissors are used to make a small incision in the anterior capsule at the base of the triangular flap, while an irrigating Simcoe cannula maintains the anterior chamber depth. The edge of the capsular flap is engaged with the Simcoe cannula. The flap is gently torn across its base in a circumferential direction and finally removed. The conjunctiva over the external wound is now closed with cauterization at both